Okay, what in the world does a skeleton have to do with the BBL? Well, it's really interesting. We're going to be talking about the OG line as it comes through the hips and how your skeleton, how your leg and your pelvis really factor into that. Watch a video. I don't think you're going to be disappointed.
Maximal projection. We want this line to be smooth. Not everyone lipos in the key area.
Okay, let's talk about this potato salad. I'm not talking about my mom's recipe for potato salad. That was good. What I want to talk about is this area here, this fatty deposit that I call the potato salad, because I always think like, oh, that's really nice. Somebody brought something to the picnic. They brought a potato salad. You know, she brought something to the OR. She brought this nice fatty deposit here that I can work from. I just want to show you that it's a little bit different in this situation than it is typically. And the reason is this is actually not as much fat here as you think it is. It's really just the shape of her femur, which is a long bone in your thigh, and there's a little outcropping of that. And that little outcropping can kind of poke out in patients. Here you can see there's a large fatty deposit here, and here's where her femur is projecting a little bit more laterally, a little bit more outward, and it's giving kind of a sharp contrast between her side of her butt and where this fatty deposit is. So some patients, you see this, it's called the trochanter, you see that kind of poking out, and it gives this look as if they have potato salad, but she really doesn't have as much fat as you would think, because really what's causing this protuberance here is the thigh bone and not just the fat. What I like to do, you know, if you look straight down here, I've not injected this side at all. So if I'm just here and I'm looking down and I'm going to inject this side, I'm interested obviously in getting more volume and shape to the butt. But one of the major things we have to get right is this OG line here. Her knee's down here. This is her leg. Now you get to this protuberant part, and then it becomes very flat through this area here. And then this goes into the key area. This is rounded. This part of the there I'm not really worried about at all. But what I really would like to do is to make this OG line a very nice smooth line that comes here. Because of this thigh bone kind of poking out more, it's going to be hard, I know, to completely get this line to come out like this the way I want it, because this distance is just too great. The tissue here most likely will not allow this to come out. And the reason I know that is because I've already injected the other side. So here she is. Her butt itself is really nice and perky and round. She's going to have a very, very perky round butt. But I'm not quite as happy with the OG here, because I wasn't able to get this area to pop as much as I would like. So it really has to pop a lot, because this is out here a long way because of her femur. Okay, let's just go back to the classroom, so to speak, and I just want to explain this to you in a little bit different way. And so I've drawn a diagram here demonstrating this area. So what we're talking about is this joint. This is the hip joint here. This is what we call a ball and socket. So the hip bone, this is the hip bone, this is the pelvis. It acts as the socket. And then the femur, or the thigh bone, is the ball. And so that ball and socket fits in there, just like this little connection. Now, everybody has a different shape to their pelvis. Some pelvises are taller, some are wider. There's a huge variability in shape of pelvis. And importantly, for what we're talking about with the hip dip area and trying to get a smooth OG line, what's very important is the angle and the relationship of this hip joint. So the relationship of the femur to the pelvis. And there are some people that are more knock-kneed. So their knees are coming in together. And as their knees come together, look what happens to the femoral head. So you get like a little protrusion here. And that was what was going on with that patient I was showing you in the operating room. She didn't really have a fatty deposit there so much as she had more of a prominence of her femur coming out, producing that sort of outcropping here. And that's what I was trying to correct with the fat, is I was filling in here so that that line was smoother. But that's the underlying reason as to why she had that fullness here. Some people just have fatty deposit, so their shape is straight and they just have fat here. But other patients will actually have a change in their pelvis, so this moves and it creates that outpouching in that area. Can look like fat, but it's not really fat, it's just the shape of the femur. So we try to camouflage that and give her a smoother line, a real OG line, by grafting the fat into that area to compensate for the movement of her femur. And that's why she had that look to begin with, and that's how we focus on correcting it.
And this is just one of those situations where, because of her femur, because of the anatomy, her tissue is not soft enough to allow me to kind of match what's going on in her lower leg, but it still looks good. It's not like an all or none phenomenon. Everything is kind of a spectrum. So that's just something I wanted to point out, because that's an anatomical sort of nuance that I haven't talked about before. And also just to kind of point out the fact that maybe we don't get everything exactly the way we want to get it just because of the tissue. You still get a beautiful result. Okay, so here's a similar kind of preoperative fatty deposit, that potato salad area, but her femur and her pelvis are differently located. She has the same fatty deposit, but she doesn't have quite as much projection of her femur. And it's the same fatty deposit, but the underlying skeleton is a little bit different. And so here, I think we were able to do that because as you see this line come up here, this was the fatty deposit area. I was able to blend this into her leg. So I was able to blend the fat, this fatty deposit into the hip. And so as a result, this is the convex part of the OG, and that line is just like perfectly smooth. It's not going up and down. So this is just another example of somebody that comes in, really similar fatty deposit, but the location and the orientation of the way the femur articulates with the pelvis is different. And so that anatomical difference gives us a little different result. We're always going for the same thing. We're always following the OG, but sometimes the anatomy permits us to get a better OG, and sometimes the anatomy prevents that. So this is an example where her tissue was really nice and soft and really cooperated, and we have a really nice, pretty shape. And if you look at both sides, it starts up in the key area, but then this just really comes out, and it's just this really pretty kind of like double OG, if you will.